On to the next talk.
Well, before I start, as the president of the Hellenic Chest Disease Society, I am feeling very blessed for our distinguished guests who are accepted to participate in our Congress. I believe that we all will aspire for their expertise. And now, I think that the most suitable for the next topic is Professor Venerino Poletti. Professor Venerino Poletti is the director of the Interventional Pulmonology Unit in Morgani Hospital in Forlì, Italy. And above all, it is a close friend of mine, and I would like to present the next topic, which refers to Cryo Transbronchial Biopsy for diffuse interstitial lung disease. Prof, the light's on you.
Kalispera. Good evening. It's the only word I know in Greek. Thank you very much for this kind invitation. I am very happy to be here in Greece, and I had the opportunity to visit yesterday a fantastic place. It's the Philip II tomb, and it was an amazing experience. These are my conflict of interest. So just a few words regarding standardization. We know how to perform cryobiopsy in diffuse parenchymal lung disease because we have a lot of documents on that. And this is how we can perform it. In our hospital, we intubate the patient with a tracheoscope, not a bronchoscope. This was the oldest cryoprobe, very, very useful. And this is the eyeball test. This is an important element, the Fogarty balloon. We control bleeding with that. A patient with a very mild disease. And we intubate the patient. We don't use muscle relaxant. They maintain spontaneous breathing. We insert the Fogarty balloon outside, and we reach the segment we want to biopsy. We inflate the balloon. We fix it. This is important. We stay a little bit further the carinus, so we can control dislodgement. We fix it into the rigid tube, and then we make biopsy under fluoroscopic control, staying quite close to the pleura, and we freeze 7-8 seconds with 1.7 and a little bit less with 2.4. When we go out, if an assistant inflate the balloon, so this is a dark period, but we control bleeding in that way. Now we have different cryoprobes, 1.1, 1.7, and 2.4, and of course we can make cryobiopsy also using orotracheal tube. In that context, you cannot use different Fogarty balloon, and so it's a little bit more difficult to have biopsy in different segments. And of course, there is no possibility to have cryobiopsy in not intubated patient or not in patient intubated with small tubes that you don't need general anesthesia. That I think is a new frontier we will deal with in the near future. Contraindication, we know that with surgical lung biopsy, that is our competitor. We have age limits, and we have some limits regarding the pulmonary function impairment, and these are the limits we recognize in an article published in 2018. But rules sometimes are done to be broken. This is a patient with ground glass opacities, centrilobular nodules, no air trapping. He was a 31-year-old male smoker with positive precipitancy as a professional exposure, almost normal volume, but the LCO of 16%, and pulmonary hypertension. BL was not diagnostic, and we performed cryobiopsy. And this is the diagnosis. This is a vein obliterated, and we have proliferation of capillaries in the alveolar septa, documented by immunohistochemistry, and the final diagnosis was pulmonary capillary hemangiomatosis. That is a completely different diagnosis compared to the hypothesis of hypersensitivity pneumonitis. We can make biopsy in patient with impairment function, but also we assess it if cryobiopsy can impair the function after the procedures. This is a study is already ended, and we saw that we don't have pulmonary decline, pulmonary function decline after cryobiopsy in this prospective study compared to a group of patients without biopsy. The diagnostic yield is around 80% according to this meta-analysis. We know that different strategies are useful, mainly biopsy in different segments or even in different lobes can increase the diagnostic yield. And we know that cryobiopsy has an impact on the treatment strategy in this group of patients. This was our study published in 2020. You see here that according to the data provided by cryobiopsy, you change the diagnosis in a fifth of cases, but in the majority of cases, you increase significantly the diagnostic confidence, and this has an impact on treatment decision. The problem is diagnostic accuracy, so we have to compare transbronchial cryobiopsy with the gold standard that is considered to be surgical lung biopsy. But we have, you know how many papers we have confirmed that surgical lung biopsy is the gold standard on this scenario? 0 papers. So we don't have any paper that compared surgical lung biopsy with another test. So we have a few studies on that. There are a lot of ethical problems. The first is from Australia, 65 cases, multi-center study, prospective study. The agreement was around 70%, regardless the final diagnosis. And when you have a diagnosis made by pathology with high confidence, the agreements reach 95%. We have a recent paper from Canadian study group. They compared, it's a little bit complex, and the result was not as good as expected, mainly in the recognition of fibrosing HP. But there are some criticism regarding this study. 4 patients were excluded because of pulmonary hypertension and 12 did not consent to participate. So they recruited 20 patients. 20 patients in 4 years. Biopsy were performed by 4 experts in transbronchial lung biopsy. This is a prospective study, so I am expecting that they perform 4 biopsy per year, or 4 biopsy in 5 years. Morphological criteria used for the diagnosis of fibrosing HP are not reported in detail, and we know that there is a big overlap between the diagnosis of IPF and fibrosing HP in this group. And finally, what is the clinical relevance of a diagnosis of fibrosing HP with UIP pattern versus IPF when the offending agents are not found? So I think the main problem of these articles is that cryobiopsy are performed in non-expert centers. It happens with surgical procedures. If you make some surgery, you are not expert in the field. Do we need guiding system? This is another important problem. Fluoroscopy is a guiding system, and we have data or some paper documented that probably guiding system can be helpful. electromagnetic navigation. We have some data or coming data on CLE, but I think that probably this could be the best guiding system. A patient with some lesions in the periphery with ground glass, with the atoll sign, intubated, breathing, spontaneous breathing, because this was a prospective study, we inserted 2 Fogarty balloon, fluoroscopy, assessment of the probe, and then CT scan guided approach. It's not important to avoid atelectasis. What is important is to know if you are in the real periphery and you perform biopsy in that way. We have this study already submitted. Patient with no typical UIP pattern, no clinical radiological diagnosis after MDD discussion, and high-resolution CT scan involvement less than 50%, assessed by an expert radiologist. These are the cases, 36 cases. Pulmonary function test is quite preserved. These are the aspects in CT scan. And you see here the diagnostic yield was quite good. We separated each sample. So after the third sample, we reached the 88% of the diagnosis, and we didn't improve significantly in the fourth sample. Safety profile, we didn't have any important complication. What is important is that we had 41% of pleura in the sample. So the sample, 41% of sample contained pleura, so we were at the very periphery, but the pneumothorax rate was 27%. This is a case, a 60-year-old patient with very mild disease, and you see here some nodules, Mary nodules, and this is a diagnosis. You see here, and in the right part, there is a nodule, typical aspect of meningothelial cells, and the final diagnosis was the meningothelial lung nodules or diffuse meningotheliomatosis. But we have another paper published by this Spanish group in patient intubated in ICU after lung transplant. Is a prospective study. What is interesting in this study is that they didn't use any guide system, no even fluoroscopy, and the diagnostic yield was good, and also the pneumothorax rate was low. So it means that probably in some context, even fluoroscopy is not useful. Pathological corner, these are the specimens. The dogma that the transbronchial approach samples only the centrilobular zones of the secondary pulmonary nodule is not true. Here we have samples showing interlobular septa, and in the right part of the slide we have, in the bottom we have the bronchiole, and in the upper part we have pleura, so we are sampling the secondary pulmonary lobule, and the biopsy can be tangential. Here we have the lesion, is an adenocarcinoma in the left part, but the biopsy entered in the right part of the sample, so we can have a biopsy, tangential biopsy. This is very central containing only bronchioles, and this is a tricky samples containing a vessel, so the most life-threatening complication is pulmonary hemorrhage. You can have a big samples, but with no pathology, so it's not diagnostic. This was diagnostic because we have pleura and bronchiole in 2 samples, and the diagnosis was NSIP. This is typical pattern of UIP with, interestingly here, even from the pathogenetic point of view, we have bronchiolar fibroblastic foci and alveolar fibroblastic foci. We know that there are some problems in interpretation, but in this paper by Australian group, the pleura was present in only 9% of the samples. And this We analyzed that study according to the pleural rate, and when you have a significant increase of pleural in the samples, the confidence of your pathologist for the final diagnosis increases significantly. We have some data on hypersensitivity pneumonitis, but again, the problem is pleura. This is a case of an SIP, 3 samples diagnostic. We have now a study with a multi-center study including patients from Prague and from Vancouver and from Scottsdale in Arizona. And interestingly, these cases had collagen vascular disease. For me, the most important message here, all the cases didn't have UIP pattern in CT scan. The most interesting message is that 25% of the cases had UIP pattern. So cryobiopsy could be interesting also in collagen vascular disease. This is a diagnosis of bronchiolitis after lung transplant, and this is a very rare case of Niemann-Pick disease type 2, and the diagnosis was made first by cryobiopsy, and this is Nerheim-Chester disease with immunohistochemistry, and even NGS. We had NGS, and this is a diagnosis of deep neck. So the ideal TBLC biopsy samples, the sample that is able to capture the area in which the process is. So according to the CT scan. So pleura has an important role in the game when we are dealing with reticulation or subpleural aspect, and the nodule and the target is the core business when we have nodules. We can use different approaches using genomic classifier or immunohistochemistry or even NGS. We can have a rapid on-site examination using these new instruments, and also this is a very interesting instrument, Vivascope. The images you have are similar to that you can obtain with histology, and you do this without altering the tissue. We have guidelines, ERS guidelines on this, and this is a very recent paper in the Lancet Respiratory Medicine. We had a study with the Netherlands group and Jürgen Etzel showing that if you select this approach, cryobiopsy first and surgical lung biopsy as a second choice, you have a good diagnostic, very good diagnostic yield with less complication. So this was my last slide, but I invite you all in the 11th edition of transbronchial cryobiopsy in diffuse parenchymal lung disease in the city in which I live, that is Ravenna. Thank you very much for your attention.
Thank you so much, Prof, for your excellent presentation. Any question from the audience? I would like to hear from you something. Do you think that pneumothorax is an acceptable complication performing transbronchial lung cryobiopsy? I mean that it seems that we have done successfully the procedure. If we have pneumothorax.
I understand the question. Yes, pneumothorax is present in 100% after surgical lung biopsy, if I am not wrong. You can have pneumothorax for a few hours because now we have very good approaches. I think that to have the diagnosis without pneumothorax is better, but the most complicated side effect, if you are able to control bleeding, is not to have a diagnosis. So I think that we try to combine both things, and so far, if you want to have a diagnosis in ILA, as we documented, you risk pneumothorax in a quarter of the cases. I do not know if in the near future with more confidence with combined CT, we could have best results, but I am not so sure. Another point is to use smaller cryoprobes, but we are now ongoing study, but I have not yet the data confirming that.
Okay.
Nerino, I think it's a great pleasure to have you with us, as always. And I think we have to congratulate you because actually you are one of the pioneers for cryobiopsy in interstitial lung diseases. And as ERS Assembly Head and participant in the guidelines, we have this technique, this methodology in the guidelines now for the diagnosis of IPF. I'm very happy that you did this study, as you said, under evaluation, about the CTD-ILD, where you are one of the task force members. We didn't evaluate cryobiopsy, only biopsy, and we didn't have data for CTD-ILD. It is important, I think, still, even if we have merged for IPF, UIP, and probably UIP, but I think for CTD-ILD is even more important to know because it is prognostically important for the patient and therapeutically also important. So I would like to ask you, your experience, which is good as far as I understood, because also the patients are younger and less comorbidities, etc. And if we can have a study or it is something ongoing to compare a genomic classifier, which is maybe easier for pulmonologists without interventional expertise, such as myself, for example, or in centers without interventional pulmonology, in comparison with cryobiopsy, even maybe with less, as you've said, the tubes or the tool could be less huge, or I don't know how you do that in your technique. So I would like your approach and your comment about it.
Thank you, Katerina. And we know, I would say good luck, Katerina, for the next future. Regarding CTD-ILD, yeah, I think that the data we have so far are based on surgical lung biopsy performed more than 30 years ago, so are very old data. And we have data only on CT scan that are not able to recognize micron coming. So this is the first paper, but it's interesting because it's multicentric, and the pathologists involved were not in our center, so we didn't have any role in the pathological decision, so it was nice for that. So I think that biopsy will be back even in this group. Regarding genomic classifier, there are good data regarding specificity, even using regular transbronchial biopsy, and in America now is almost the gold standard. We started again with this study in Europe with genomic classifier for with cryobiopsy, but with genomic classifier you have the diagnosis of UIP and non-UIP, so you don't have the other things around. So the first limit is that one. Sorry?
Tissue is still the issue?
Yes, yeah, I think so.
Okay. Dr. Panago, a quick question, please.
As you said, the genomic classifier tells you that you have fibrosis, but not what fibrosis. What kind of fibrosis you have. It doesn't tell you that. It
tells you that you have UIP.
Yes.
It doesn't
tells you that you have, but what else? That doesn't tell you what other is. So my question is, I'm sorry if I upset you a little, but in a fibrotic lung, I wouldn't touch the lung. I wouldn't touch it. I wouldn't perform it. Now, instead of doing cryobiopsy, it's better, and now it's emerging, confocal microscopy. You can see, you can make that diagnosis, you can see what is going on in the lung, you do not perform any biopsy, and you have you can see the lesions and what's going on. Fibrotic confocal microscopy.
Now, we made a paper already on that topic, The problem we published in respiration, now we have an ongoing study with CLE. We don't have data, solid data saying that which kind of fibrosis is there. We could use it in order to select the target. This is the project we are preparing for nodules and even for diffuse lung disease. So regarding the imaging system, I think that optical coherence tomography have some data that could be helpful in order to recognize on a coming. There are at least 2 or 3 papers on that. CLE is more useful, we think that could be useful for the targeting. Yeah.
This has to be proven. Okay, for lack of time, we should go on quickly to the next and last topic.